Good afternoon, everybody. Thank you for joining us and taking your time. I am truly honored to be named as this lecturer in my belief that continuing medical education is the most vital factor we can do as physicians. We were talking about Tinsley Harrison, who is editor of the famous textbook of internal medicine. And on his bust, he wrote, "No greater opportunity, responsibility, or obligation can fall to a human being than to become a physician." But we must remember that along with this is the heavy burden of lifelong learning. Every healthcare provider must do this. If it is not performed, think about the potentially great harm we can do to those we care for. I'm extremely grateful and honored that Dr. Vikas Khurana, my former fellow, a friend who has a love of medicine, and if you meet Vikas, you'll always find he's seeking explanations for the unknown, has honored me by sponsoring this lecture. Okay. It's also underwritten by the Fortunoff Fund for Pancreatic Research, period. These people care about other people. We are thrilled that the inaugural lecture will be by Santhi Vege. He is professor of medicine at Mayo Clinic in Rochester, but most importantly, he is an amazing individual. He is known throughout the world as a force of medicine and pancreatology. He has amazing clinical acumen, has written extensively on clinical projects, has created a new generation of teachers. He is the perfect person to give this inaugural lectureship. I just want to thank Vikas and Santhi to say thank you from the bottom of my heart for honoring me. Our chief resident, Kelly Corbett, will introduce Dr. Vege.
Thank you, Dr. Barkan. Welcome, everybody. So for our introduction today, Dr. Santhi Vege is originally from Nellore, India, and attended medical school at Gunther Medical School, followed by residency in internal medicine at Government General Hospital, Gunther. He then went on to complete a gastroenterology fellowship at Postgraduate Institute of Medical Education and Research before finally coming to the United States and attending Mayo Clinic in Rochester's internal medicine residency. He has 39 years experience as a staff physician in academic gastroenterology and pancreatic diseases with a special interest in pancreatitis. He currently is professor of medicine at Mayo Clinic in Rochester and has been the director of the Pancreas Group, as well as the program director of the Advanced Medical Pancreatology Fellowship, which was the only program in the country until recently, for 13 years. He has published over 250 original papers, including the pendoxifylline trial in acute pancreatitis. He's published in JAMA, New England Journal of Medicine, Gastroenterology, and Gut, amongst many others. Along with this, he has also written textbook chapters, including those in Up to Date. He's participated in systemic reviews and is involved in changing practice guidelines. Dr. Vege, you can go ahead and start.
Yeah, thank you very much, Kelly, for the nice introduction, and Professor Barkan, Professor Khurana, and other distinguished colleagues. It is indeed a great honor and privilege for me to actually do the first endowed Professor Jamie S. Barkan lectureship series, and a couple of sentences I would like to say about Professor Barkan. I call him Jamie, but today I will address him as Professor Barkan. More than 20 years ago, I was introduced by my senior colleague, Jonathan Klein, who since retired, at one of the APA meetings in Chicago to Professor Barkan. Jonathan told me that you have to meet this distinguished and unique individual. And I was so impressed with him during the first meeting. And he looked so professional, so nice, so caring, so trustworthy. And since then, I have seen him in every single pancreas meeting without fail. He is always there. He's always asking laser sharp questions at the end of presentations. And his immense commitment to attend meetings and to ask questions and to talk younger colleagues is something which I would like to emulate myself. And I would request the younger people that you cannot get a better role model than Professor Barkman. Jamie, this is an honor to give this lectureship series. And today I am going to share my screen. I think I'm just trying to see how to do it. I hope Laura is somewhere there to help me if I don't share it properly. One second, sorry. Can you all see this?
Perfect, yes.
Okay, so my today's talk is chronic pancreatitis, which is very dear to me and also dear to Professor Barkan and probably many of you too. And I also bring greetings from Rochester, Minnesota. Just about 2 weeks ago, it was like this, believe it or not. It's a little bit different from Miami, as you would agree with me without any argument. These are my disclosures. I don't have any commercial stuff going on except the royalty for up to date. And I have these 3 NIH grants. And I just got a very big Department of Defense grant for a drug trial in acute pancreatitis, which is very nice. And chronic pancreatitis, as we know, in a simple manner, first of all, it has been for the first time described in 1946 by Professor Comfort in Gastroenterology paper, so from Mayo Clinic. So it's, I think, I feel it really a privilege to give a talk on this topic. Pathology is inflammation, fibrosis, destruction of architecture of islets. And clinically, these people will have pain, upper abdominal pain, exocrine and endocrine insufficiency, and complications. And imaging-wise, they show calcifications, ductal dilation, and atrophy of the gland. And the typical example, as we know, the so-called classic or usual CP is alcohol. It's actually a shrinking syndrome. So many of these things have been gradually removed, and they form their separate entities, like, for example, obstructive pancreatitis due to tumors, necrotizing pancreatitis and trauma, autoimmune pancreatitis, hereditary pancreatitis. These all now are removed from the term CP and they're separate. And the classical or usual CP that we talk about now is senile or late onset, alcohol with or without smoking. These are the 2 things that we mean when we say CP these days. Then you have entities called pancreatopathy. For example, in people with diabetes, renal failure, and just only alcoholics without any clinical features of this thing. What pancreatopathy means is if you can get a tissue from these people, it shows fibrosis, but there is no inflammation and there is no destruction of architecture. Whether this will eventually lead to CP or not is not known at the present time. So I would like to talk today, the outline would be definition, pathogenesis, correct diagnosis, etiology and severity, pain relief, endocrine dysfunction, exocrine dysfunction, nutritional status, local complications. So if you look at the definition of CP, starting from 1963, when the Marseille classification came in, then, modifications happened, Cambridge, Japan, Zurich, NAPS 2, that is Dave Whitcomb and his colleagues. Then the Germans have come up in 2013. And the most recent is IAP, International Association of Pancreatology. It's called mechanistic definition. There are some issues with this, but that's the most recent one. And there are several pancreatologists from different parts of the world participated in this. If you look at the background of CP, main example is alcohol, as we all talk about. Comfort et al. Originally described this as a chronic relapsing pancreatitis, and they said it is a summation of repeated attacks of pancreatitis. April and May, there are 2 papers in Gastroenterology, 1946. That's when chronic pancreatitis started as a separate entity. Then Aman from Europe modified it a little more further, saying in early periods, you have relapsing episodes, and in the intermediate phase of the disease, few years later, the pain becomes chronic with local complications like pseudocysts, biliary entrapment, etc. And he said that in the late stage, the pain disappears. This is something which has been fiercely fought for the last 2 decades. Will the pain actually disappear or not? Then Peter Weyer, who is from Germany, who spent a few years with Jean DiMagno here in Mayo Clinic in the 70s, classified CP. The first one is alcohol, the typical one. Males are more frequent, high frequency of calcification, steatorrhea, and diabetes. Then the idiopathic one, which Aman described, he classified them into early onset and late onset. And early onset is the one which has pain initially and a long painful course. And the late onset one, which is usually in elderly individuals after 60, although it's probably 60 is not elderly anymore, they're young people, because I'm also past 60. So this they call senile, but here the typical feature of this is mild or no pain. The calcification, steatorrhea, diabetes will proceed with a slower rate and less frequency in this idiopathic, both early and late onset. If you look at the mechanisms, how the CP happens, necrosis, fibrosis is what Comfort, Aman, and Koppel, they all said. That means you have some necrosis, whether it's seen on imaging or not seen, and that gradually causes fibrosis through stellate cells and other features. Direct toxicity, example, alcohol on the acinar cells. Duct dysfunction, obstruction, and protein plug formation, oxidative stress and free radical formation and damage. But Dave Whitcomb came up in 90s SAPE hypothesis, which is sentinel acute pancreatitis event. What he said, and most of the pancreatologists subsequently subscribed to this, is that all CP start as a clinical attack of acute pancreatitis. And in some individuals, that triggers repeated attacks of acute pancreatitis, stellate cell activation, various other mechanisms, and fibrosis formation. In other words, what basically they said is that every chronic pancreatitis has to have an acute pancreatitis to start with. We'll talk a little more about this later. Then there is activation of unfolded protein response. I am not a basic scientist. I'm a pure clinician. So most of my talk from here will be predominantly clinical. So we also have to know what is RAP and what is IRAP, recurrent acute pancreatitis and idiopathic recurrent acute pancreatitis. It's not easy to say. I mean, I still don't know what, there's confusion about these things. Some restrict RAP to those patients not leading to CP, but most of the pancreatologists now think acute pancreatitis, RAP, and CP as a continuum, something like a SAPE hypothesis. You start with acute pancreatitis and go through RAP and get CP. But a very interesting question that I have always posed to myself is, the RAP and IRAP, do they lead to CP eventually? Or in some of them, there is CP already established, but clinically silent, and has come to the surface clinically as AP and RAP. But even during the first attack of AP, suppose if you have a tissue diagnosis, they already have established CP. This is an interesting question, actually has not been sorted out. So I don't want to confuse you with these things. I know it is very confusing, but the questions in the relationship between acute pancreatitis and classic CP, because SAPE hypothesis says that you have to have AP to start with and only then it leads to CP, are, number one, how often does AP progress to CP? Because we see AP all the time. Does CP always or mostly evolve from the prior AP, as SAPE hypothesis and several experts feel? And lastly, the third question is, do RAP and idiopathic pancreatitis lead to CP, or are they the clinical manifestations of already established silent CP? These are the three important things. So taking the first question, we have several studies now in a meta-analysis which clearly says that The progression from AP to CP is highest risk in smokers, alcoholics, and male sex. And the pool prevalence after an attack of AP of RAP is 22%, and 10% is CP. That means if you take 100 cases of AP and follow, 10% of them will go to CP overall. And if you take the RAP patients, the 22%, then 36% of them will develop CP. So that's the best meta-analysis and summation of all studies. But the question is, in these people where we say the first attack AP, how many of them have already existing CP, which is silent? That's not known. And that's the million-dollar question, which has not yet been answered. And if any one of you young pancreatologists want to take this up, which is going to be a long study, that will be great. The second question is, does CP evolve most of the time from prior AP? Here, the SAPE hypothesis I have talked. And according to the SAPE hypothesis and the new mechanistic definition, you have 5 stages from A to E, and E is established advanced chronic pancreatitis, and A is actually people at risk, like we don't know how to identify them, but this is the genetic hypothesis people are talking. And I will show you this here. So you can see that the A is susceptibility factors. That means people who are alcoholics who may have some genetic abnormality. Then B is when you have acute pancreatitis episode, and then that triggers in some people the SAPE hypothesis, and you go through various stages of early CP, established CP, and end stage CP. What I did because of this question, I have started seeing in my practice that most of the people where you make a diagnosis of CP, they never give you a prior history of AP, whereas the SAPE hypothesis says that everybody has to start from AP. And it's only in few people, or maybe half of them. Then I looked at 500 patients that we have seen CP in just 3 years. You can see this 2018 publication. And just to see the number of the volume of patients we get in 3 years is 499. And about 13 centers for the NAPS2 study got 521 patients in 4 years. 13 centers, 4 years, 521, 3 years, single center, 499. Anyway, the point here is, I looked at the NAPS and I looked at the Hungarian study, and everywhere, 30 to 90% of the people did not give a prior history of AP, which is what SAPE hypothesis says you should have the AP history. But people can say these are all retrospective studies, and you may have, the patient may not have given you the prior attack of AP. Then we went to the Olmsted County publication that we did, about 90 patients of CP. And in Olmsted County, 95% of them are taken care of in 2 hospitals. And if they have an acute pancreatitis, they should be admitted or the ER visit in this county. So we found that only 52% of them had prior AP. So this is actually validating the publication we did, and also what we found in other studies, and the prevalence of alcohol in all these studies is equal. So basically what we are saying is, the SAPE hypothesis, we differed from SAPE hypothesis, saying that a large majority of CP will not have a prior AP. There must be other mechanisms which produce indolent chronic inflammation going on for many years, silent, but then coming to the surface clinically with either chronic abdominal pain or even an attack of acute pancreatitis. So that's what I am showing here. So this is already done. And the third question is, can these be the clinical manifestations of an already established underlying CP? So we know that people who develop the first attack of acute pancreatitis due to alcohol, and we have studies where some surgical biopsies have been taken during the first attack, or some of them died and autopsy studies have been done, they already have, by the time they had the first attack of acute pancreatitis for which they have come or they have died, the pancreas already has full-blown chronic pancreatitis, and they did not have any clinical manifestations prior to that, which means that the chronic pancreatitis was going on for years in a silent manner and presented for the first time as acute pancreatitis. This is what is important. When you have idiopathic acute pancreatitis or RAP, You always say that after 12 weeks, if no cause is found, you do the endoscopic ultrasound. Why? Because you look for microlithiasis, which is missed on MRCP and CT. You look for small tumors missed on MRCP or CT. But nearly 30% of these patients will show chronic pancreatitis in various series. So some of these people have been having chronic pancreatitis, and the first clinical manifestation is AP. And it's not AP subsequently going to CP, but CP has been going on in a silent manner and has resulted in AP as the first clinical manifestation. I know I'm only telling these things to those people who want to take a deep dive in the relationship between AP and CP. And this probably is not so important for a practicing clinician, except to know a little bit about this. So I apologize for dwelling too much on this. So the take-home points. AP progresses to RAP and then to CP, 22% and 10%. Alcohol, smoking, male sex are risk factors for such progression. Only 10% progress to CP. And macronecrosis causes obstructive chronic pancreatitis. And micronecrosis, probably the classic CP that we know. I have already talked about the thing. And probably some of these things may be cleared. Two things important. The quest should continue to understand the mechanism of indolent CP going on for many years, but presenting for the first time as AP. Probably unfolded protein response, probably something different in these people. And the prospective study by the NIH consortium called PROCEED, 9 centers, I am the PI for Mayo. Hopefully, this may throw some light in the next 5 years when we have all the reports, genetic, etc., etc. Okay, now we move on to the diagnosis. The most important thing in chronic pancreatitis is exocrine insufficiency, as you know, which is called exocrine pancreatic insufficiency, EPI. That's the term that is used. You have to have a high degree of clinical suspicion when they have foul-smelling, bulky stools with oil droplets, even bulky stool, which is sticking to the pan. Even if it is only 1 or 2, you have to think about it. And still the gold standard is fecal fat is quantitative, 24, 48, or 72 hours. I know that everybody is going away and there are very few centers doing it. We still do it in large numbers and for most of the people, if possible. Serum trypsin has not caught on very much. Fecal elastase is by far the most commonly employed test on a worldwide basis. Definitely less than 100 micrograms is very reliable, although less than 200 also people say could be, but it has many problems. And the tube test, the secretin endoscopic test, are a dryling tube with CCK, pancreozymin. Even we have not done, although we have the dryling tube, a test in the last 2 years, as I was talking to the laboratory. It's almost extinct now. Endoscopic pancreatic function test, few dedicated, committed endoscopists are doing. And C13 trialing breath test, which we are trying to establish at Mayo, as well as some other centers, and also for the NIH consortium. The biggest proponent is Dominguez Munoz from Santiago del Compostelo in Spain. He has done more than 1,300, 1,400 tests. And it's a 4-hour test, but it's actually the triglyceride is the C13 labeled stuff that is given to the patient. And if it is properly digested by the pancreas, in the breath, you have X amount of C13. And if the pancreas is deficient, the C13 in the breath will be decreased. That's the policy. But it's a little longer test, but we are trying to set it up because of the problems with the fecal elastase. Low sensitivity, low specificity, liquid stool will have problems, and there are so many non-pancreatic diseases where it can be abnormal. And of course, secretin MRCP has come into the picture as a pancreatic function test. Next is the imaging, and we all know CT, MR, and EUS are the 3 imaging tests that we use, and we are all familiar with this type of chronic pancreatitis with a dilated duct and parenchymal calcification and some ductal calcifications. This is actually advanced. The terms, I just want to mention the so-called the early pancreatitis and minimal change chronic pancreatitis. There are many issues. I've written an editorial just about 2 months ago in GI endoscopy. Those of you who are interested to know more about it can read that. The terms have been variously defined, early and minimal change. The diagnostic criteria are completely different in various studies, and whether it progresses to chronic pancreatitis or not is not known. So there is a huge amount of controversy, and I don't want to really talk about it much. Right. So we have to make a correct diagnosis here. Never give a label of chronic pancreatitis easily just because some minimal pancreatic enzymes are elevated and some abdominal pain is present, because this label goes down on the patient for reputed institutions if they diagnose a patient as CP. Advanced is very easy, CT, MR, we know the things, but early is very difficult, and we don't even know what is early or minimal change, as I've already told you. Many chronic pain patients with equivocal pancreatic enzyme elevation may not actually have a pancreatic disease, as we all have investigated hundreds of those patients. They may be just irritable bowel syndrome, functional dyspepsia, etc. We say that EUS is very sensitive, particularly when MRI, CT do not suggest CP, but it's not specific. We know that too. And we usually say 5 or more criteria out of the 9 criteria, or Rosemont major, minor criteria. We say that it is CP. But what about people who have abdominal pain, CT, MR normal, and we do an EUS and we find 5 or more criteria or Rosemont? Can we confidently say that they are a CP? No, I don't think so. Because you can have, if you go to the Japanese early pancreatitis criteria, you can have even 7 EUS criteria. And unless they have certain clinical enzyme and alcohol history, they don't take the 7 criteria as early chronic pancreatitis. And even when they have made a diagnosis of early chronic pancreatitis with other things, along with 5 or more EUS criteria, when they followed them, some of them actually regressed the criteria, and many of them did not progress over a period of 3 to 4 years to chronic pancreatitis. So there is a lot of uncertainty about the terms early and minimal change. And probably in these people where you have a doubt, pancreatic function test may help. And if you also have a pancreatic function test abnormality, then you can probably be a little more confident that they have CP. And that's where the endoscopic pancreatic function test, which is used, can be clubbed to be more definite in questionable cases. So lastly, the treatment, the goals of treatment are pain relief, obviously the most important thing, because 80% of the people will have troublesome pain, endocrine insufficiency, exocrine insufficiency, and nutritional deficiencies and local complications. Local complications means pseudocyst, biliary entrapment, head-forming chronic pancreatitis, where there is always a question of pancreatic cancer, and pancreatic cancer, which is about 4 to 5% incidence in chronic pancreatitis. Not a whole lot. That's why there is no screening for pancreatic cancer in chronic pancreatitis. So the pain, 85% have pain, more than $500 million annually spent on this pain relief, low quality of life, high resource utilization, and disability. But we need to understand why people in chronic pancreatitis have pain. For years, we said, and based our treatment decisions on ductal hypertension, we said whenever dilated duct, greater than 6 or 7 millimeters. We also said parenchymal hypertension because of fibrosis and something like compartment syndrome of the pancreas. We said pancreatic neuritis, that the nerves within the pancreas are inflamed, hypertrophic, and causing pain. And then the complications can cause pain, like cancer, stenosis of CBD, stenosis of pancreatic duct, duodenal stenosis, pseudocyst. But there is more than this as the mechanism for pain. So recently we understand pancreatic neuropathy, peripheral intra and extra pancreatic nociception, central spinal neuropathy, central cerebral neuroplasticity. Whatever name you give, the so-called peripheral and central sensitization is very crucial to understand. And I would just like to show this beautiful slide, which is a 2011 publication. What basically is happening is, if you take the pancreas, you have pancreatic neuritis in the initial stages, the nerves in the pancreas. But once 3 to 4 to 5 years pass, then this sensitization of the afferent nerves going to the spinal cord, posterior root ganglia, then the posterior spinothalamic tracts, and the thalamic cerebral tracts going to the sensory cortex in the posterior part, and then descending inhibitory pathways of pain. All of them get abnormal. They change. Some new channels like sodium 19 channels open up. But simply, this is called central and peripheral sensitization, which happens after 3 to 5 years of any inflammatory process, not only in the abdomen, anywhere. That's, people call it sensitization, neuropathic pain, whatever name. But the important thing here is, now, no matter what you do on the organs, here we are interested in the pancreas, but it can be, inflammatory bowel disease or something else. You can do endoscopic treatment, you can do stent placements, you can do sphincterotomies, you can do total pancreatectomies with or without islet cell transplantation. Once this sensitization has happened, the pain continues to be present because it is coming from the abnormal nerves and not from the organ and the disease which you are treating. That's the reason why you have, even after total pancreatectomy, 30 to 40% of the patients will still have narcotics. So these have to be approached. And particularly if people are using narcotics for more than 1 year, the opioid-induced hyperalgesia that they cause actually add fuel to the fire and make the sensitization process even more. That's the reason that in people who have pain for 5 years, taking narcotics for more than 1 year, no matter what procedures, interventions you do on the pancreas, you have a substantial amount of failure only because those are the people where this process has happened. Okay, so we have non-opioids. This is the WHO pain ladder. Then, we have to restrict the opioids in these people, but it is easier said than done. Pancreatic enzymes, most of the meta-analysis does not suggest they benefit, but some people feel that there may be a small proportion of patients. Antioxidants, for sure. Endoscopic treatment, surgical treatment, which can be resection, drainage, with without islet cell transplantation. Celiac block, some questions. And pain management and rehabilitation, where you have a variety of cognitive behavioral therapy, neuropathic medications like pregabalin, then, TENS and stuff. It's actually a good comprehensive program going for 1 to 2 to 3 weeks and then supervision. But there are very few programs not covered by insurance, expensive. Patients don't want to go through them. So it's most often, theoretical than actually happening. One word about pancreatic enzymes for pain relief. The Cochrane review showed no benefit for pain relief, but the uncoated enzyme, we have only one case out of the 6 pancreatic enzymes we have. It reaches the duodenum because it's not coated. And in the duodenum, you have CCK receptors, and it binds to the CCK receptors, the uncoated enzyme, and blocks them so that they don't stimulate the pancreas, which is the negative feedback loop we have. And by decreasing the pancreatic stimulus, the pain is benefited. There are 2 randomized controlled trials only in abstract form. One is Braganza's group from UK, and the other is Phil Tosca's from Gainesville, way back. They have never been published fully, but this, sometimes you can still try case, but the only problem with that is it's expensive, and 80 to 90% of the time you'll fail because the insurance companies don't cover. But if you can, it is worth giving in some people, but it has to be given with PPI because it is uncoated. But even giving regular coated enzymes, the discomfort due to undigested food, which reaches the small bowel and causes cramping, gas, etc., borborygmi, may be brought down. So that's the role of pancreatic enzymes for pain relief. And the antioxidants are supposed to decrease the oxidative stress, which is the mechanism for inflammation. So vitamin A, C, E, selenium, methionine, and zinc have to be given, whichever form. We have some commercial preparations, more often in Europe than here. And although 2 RCTs, one from UK and one from India, have conflicting results, the meta-analysis of all the trials so far now has shown that they are of benefit, and even antioxidants with pregabalin are of benefit. That's also an RCT. I usually give in the natural form in my practice. I ask them to take colored vegetables, green, red, yellow, go to the grocery and make them as good part of your lunch and dinner, and take berries, whether dry berries or fresh berries, and also take multivitamin with minerals. This is my antioxidant combination. There's absolutely no harm, and maybe there are other health benefits too. Now for the pain relief, we come to the endoscopic treatment and the most recent updated ESGE guidelines 2018. If you have calcific pancreatitis with stones more than 5 millimeters in the pancreatic duct, you have to resort to S-well. Without S-well, you cannot treat more than 5 millimeters with your endoscopic laser lithotripsy, electrohydraulic lithotripsy, mechanical lithotripsy, etc. You can either just use S-well alone, or you may use ERCP, depends on the pancreatic strictures and the complicated anatomy. If you only have dominant stricture of the main pancreatic duct, maybe without stones, then the endoscopic treatment is stent French single plastic stent, but it has to be kept for 1 year. And in this 1 year, at least 2 to 3 times you have to change it, even if they're doing well, because if it gets blocked, there can be problems. Now, of course, most recent gastroenterology, the current issue has the self-expandable metal stent also in the main pancreatic duct for chronic pancreatitis ductal stricture. Some of you may have read that paper. It is Nagi Reddy's group from Hyderabad. And then if strictures persist after 12 months, then you can go for multiple plastic stents, more SEMs, or actually surgery. But the important thing is, okay, continuing further the endoscopic treatment, pseudocysts, of course, we always treat them, chronic pancreatitis pseudocysts, not acute pancreatitis pseudocysts, with endoscopic therapy. EUS guided if there is no bulge or if there are varices due to splanchnic venous thrombosis. If they're very small, you can do a transpapillary stent if it is communicating with the main PD. But if it is a sizable pseudocyst, it is known now that cyst duodenostomy with pigtails is better than cyst gastrostomy, which is more likely to close. For at least 2 months, you have to use at least 2 double pigtails. And biliary strictures, which happen anywhere from 5 to 20% of these patients because of fibrotic process constricting the bile duct in the pancreas head, so-called biliary entrapment. These people may have to have multiple plastic stents or SEMs for 1 year with exchange every 3 months. But the problem here is the compliance of these patients is very poor. They don't come back for re-exchange of the stents. And the surgeons always say that they can do one-time choledochojejunectomy if you are not doing a Whipple for a head-centric chronic pancreatitis. Celiac plexus block, very commonly given. There is no randomized controlled trial of celiac plexus block with other therapies that it helps. But because people do feel some relief, at least at 50% of them, this is the most commonly used one. And probably the EUS guided one is better than percutaneous in one randomized controlled trial, but most commonly it is done percutaneously. I need to go to next slide. Somehow it's not advancing just. Okay. Then we come to surgery, which is very important. Medical treatment is modest with the medications, enzymes. Endoscopic treatment is inferior to surgery in the only 2 RCTs, actually now 3 RCTs. The most recent Dutch RCT, which is, I think, Python, if I'm not mistaken, I keep forgetting these names. It's a Marco Bruno's group. He's the one who first published the smaller study in New England Journal of Medicine 15 years ago, then published the follow-up study in gastroenterology after 7 years. What basically they say is that there is a higher percentage of pain relief with surgical procedure, whether it is Partington-Rochelle or Fry's procedure. Most of them have calcific pancreatitis compared to endoscopic treatment without shockwave lithotripsy. 2, it is more durable with surgery. 3, it's a one-time procedure as opposed to 2 or 3 ERCPs, shockwave lithotripsy, etc. And 4, even in people who responded with pain relief in endoscopic group, about 40 to 50% of them subsequently recurred and have to be operated. Different surgeries have been performed, which I'm going to talk to you. They can be drainage procedures, pancreatic duct, duodenum, CBD, pseudocyst. They can be resections, and sphincteroplasty, splanchnicectomy are hardly ever done now. The resections are distal pancreatectomy for focal pancreatic CP in the tail. Central pancreatectomy is rarely done except in few centers in Europe because of 2 anastomosis and then leak rate. Proximal pancreatectomy, Whipple or traditional or pylorus preserving, more often done when you have a doubt of a cancer in head-centric mass-forming CP in the head. But Most of them are actually not going for Whipple now, but duodenum preserving pancreatic head resection, so-called DPPHR. The bigger, Fry, Hamburg, and Burn are the 4 things. But the most common one, particularly in the United States, is by Fry. Professor Fry used to come till about 5 years ago for the pancreas meetings when he was 88, 89. It's only in the last 4 years he stopped. Amazing man. Then, of course, you have total pancreatectomy with or without islet cell autotransplantation, TPIAT. Okay, when should TPIAT be done? Because this is, there are a large number of centers now doing this thing. I know University of Miami is actively participating too, but few words of caution that I feel, these are my personal beliefs, you don't have to agree with me. It's a radical and irreversible operation. There is morbidity and mortality. This is my main caution, if the sensitization has happened, and if we catch these people at that time and do any procedure, including TPIAT, a good proportion of them may not respond. So we need to have new ways of diagnosing how to diagnose sensitization so that we stay away from any of the interventions and send them for, the pain rehabilitation menu of stuff that they have. The long-term insulin-free state is still only about 20%. I'm sure with refinements, this will improve. And also there has never been an RCT of TPIAT with other surgical procedures. So what I would think is it should be done as a sort of study in expert centers. Probably I would say that about 6 to 8 centers in the United States have to rigorously study this with uniform criteria, all of them following the same protocol to the great extent, and they can actually analyze the big results of all 6 or 8 centers every 1 year and come up with what's the way to really see who are the people who best benefit with this thing. And that's not happening. That's my problem now. There are at least about 15 to 20 centers with very minimal experience, not like University of Miami or University of Minnesota or Johns Hopkins, where there's a big experience. And those are the centers which I would like to see having a uniform protocol. Okay, now some pictorial descriptions of chronic pancreatitis thing. If you have a mass in the head like this and not a big dilatation, you can actually probably do Whipple, particularly if you're also having some features here as well as clinically of cancer. And if you have a head mass and a dilated pancreatic duct, the Fry procedure is the best, where you do longitudinal pancreaticojejunostomy for this dilated duct, and you core out all this tough tissue here, and then you can see if there is a cancer, and also if there is biliary entrapment, that gets relieved. But if you have a chronic calcific ductal and parenchymal calcification with dilated duct, you can do Partington-Rochelle, but Fry's will be better because you can core out all the calcific material and you can do Partington-Rochelle for this. Fry is nothing but Partington-Rochelle and coring out of all the head of the pancreas, of all the fibrotic and the stones. And if you have a single stone close to the ampulla, which is, then you can go for endoscopic therapy as well without ERCP. And if it is less than 5 millimeters, you can just go for ERCP, use your electrohydraulic or laser lithotripsy, break it and extract. And in people with non-dilated pancreatic duct, some people said V-shaped pancreaticojejunostomy. That means you excise all the tissue on both sides of the duct and make it into a bigger duct, and then you do this. Or you can also do total pancreatectomy with or without islet cell transplantation. And lastly, endocrine insufficiency, that is diabetes. This is called type 3C due to pancreatic disease, as you know. We have to get hemoglobin A1C every year. This is very different from type 1 and type 2. And actually, there is a consortium of 11 centers going on, what is called T1 DMAP. And I'm a consultant to the West Coast Centers for this. This is an NIH consortium. And this diabetes is different from the rest because here the pancreatic polypeptide response to a meal is diminished as opposed to type 1 and type 2. Hypoglycemia is very common because glucagon is also lost, and glucagon usually prevents the hypoglycemic episodes. And best agents are metformin and insulin for this type of diabetes. And one word about the exocrine insufficiency by MRCP, as I told you, is now being used. In MRCP, besides the structural thing that you want to see, the dilated duct stricture, side branch dilatation, you also see how much of the duodenal opacification that happens, and it gives you an indirect assessment of the exocrine EPI. Like, for example, D1, gradually when you follow, you can see there is very minimal duodenal opacification, more amount of gadolinium and pancreatic juice coming here. And then, now D2 is filled. Now from D2, it's going to the D3, D4, almost D4. Here it's D4. This is normal. But based on the amount of filling, you can grade these people about their EPI. But you have to understand, here you are only doing the ductal function and not the enzyme. That means you are actually looking at this hormone secretin function and the bicarbonate and the volume only, not the pancreatic enzyme output, which of course, even with endoscopic pancreatic function, you only see the volume and bicarbonate, which is one component of EPI. The other component is how much of trypsin, lipase, amylase are coming. And for that, in good olden days, we used to do CCK pancreozymin or dryling tube test, but now we don't have that. Fecal elastase is a surrogate, but I already told you about the problems of the fecal elastase. And pancreatic enzyme therapy, which is very important, and the landmark paper of the Magno in New England Journal of Medicine from Mayo Clinic showed that you have to have 90% destruction before steatoria and diabetes. So God has given us 90% excess pancreatic function so that we can drink. So usually 300,000 international units of lipase is delivered to the duodenum after a meal in human beings. The international unit is not what we use in the US. We use United States pharmacopoeia. One international unit is 3 USP, which is what we use here, or 3 European pharmacology units. Our enzyme preparations are all in USP. So if you say 10% of normal, 300,000 international units means 900,000. You are talking about 90,000 USP should be there with each meal. Most experts and guidelines recommend giving 75 to 90,000 USP with meals and half with snack. This is the recommendation, but I think this is way too high. And I'll tell you why. But you have 5 coated enzyme preparations with either mini spheres, microspheres, microbeads, etc., and only one uncoated, that is Viocase, which we have already talked. And they come in different. Lipase units is what you need to know. Do not bother about the amylase and protease units because they are easily replaceable. All your decisions are based on the lipase units. I usually start with 30,000 units of lipase, 10,000 units, 3 tablets, 1 at the beginning and 2 during the meal. Dominguez-Munoz has done trials whether you should give it at the beginning of the meal, at the end of the meal, or spread throughout the meal. So the best thing based on that trial is 1 at the beginning and 2 during the meal if you are giving 3 capsules. Check compliance that they are taking actually. You can increase up to 72,000 units of USP with meal. If no improvement, you can add PPI even to the covered coated enzyme preparations like Creon and Zenpep. If there is no improvement, check for SIBO, very common in these people, and treat that. And if there is no improvement, actually check your diagnosis of CP. But if you increase to 96,000 or 120,000 like people usually do, David Graham has written a beautiful paper on the problems of all the trials with pancreatic enzymes, which are only done to get FDA approval, not really clinically useful trials. So you are only helping the companies if you go beyond 72,000, except in rare circumstances. The patient will not be benefited at all. And these are very expensive. So a word about metabolic bone disease and nutrition. The osteopenia and osteoporosis together called osteopathy is almost 2/3 of them will have, and the same frequency as in other diseases like IBD, celiac disease, gastrectomy. And surprisingly, even though it is 2/3 will have osteopathy, only about when you look at the D3 levels, they are not different from healthy controls, although they are deficient in more than 50%. So people say that there is there are other mechanisms other than vitamin D deficiency that causes osteopathy in these people. And like, for example, even low vitamin K can cause osteopathy and DEXA scans abnormal. And it is recommended now you have a DEXA scan at baseline and then maybe once in 3 years as you are supplementing calcium and vitamin D. And these fat soluble vitamins measure every year. So last, coming to the end, make the diagnosis in a firm manner and responsibly. Try avoid narcotics as much as you can. Once a narcotic, usually narcotic, this is very difficult to take them off. Stop alcohol and smoking, very important. Check nutrients, exocrine and endocrine function. Start PERT, the enzyme therapy if abnormal. No use usually beyond 72,000 units. You may be surprised that I'm saying this, and many experts will tell you no, it is not correct, this statement. Uncoated enzymes can be tried if your insurance permits. Antioxidants, certainly, liberally. Interventions to be done in the first 5 years, preferably, whether it is a surgical intervention, endoscopic intervention, or even if you have decided TP-IAT, because subsequently a great majority of them have developed sensitization and may not respond. Single stone close to the head, as well with without ERCP. Dense stones, strictures, Fry or Partington Rochelle better, particularly in younger people. Head mass, Whipple or Fry's procedure. Biliary entrapment, multiple stents or SEMS 1 year, or choledochojejunostomy. Pseudocyst is always endoscopic therapy, preferably cyst duodenostomy. Total pancreatectomy rarely done, and in select situations TP-IAT, which has to be pursued as a research study in few expert centers so that we will have definite information in few years. A multidisciplinary team is essential, and I use this statement, don't marry in haste and repent in leisure. This is, if you do the wrong thing, like, total pancreatectomy for the wrong patient or things like that, it can be a disaster. So with this, I stop and encourage discussion, questions. I know that most of you may have different ideas. You may differ with me. That's perfectly fine.
Santhi, an elegant discussion of the spectrum of chronic pancreatitis. You set a very high bar for future speakers to reach. Thank you again. One initial question for the people in the room who may not recognize as pancreatopathy with pancreatic exocrine insufficiency. Can you talk about the causes of it and when it occurs? Okay, very good question. Thank you, Jamie. So pancreatopathy is usually seen in diabetics, elderly individuals, renal failure, and also people who smoke and who drink, but not tremendously, but have no symptoms whatsoever. Imaging is normal. When we had the autopsy on these people, the pancreas was abnormal, but it differs from chronic pancreatitis in the sense what it has is only fibrosis, and it does not have acinar destruction and architectural destruction, and it also does not have inflammatory component. Those three should be present to make a diagnosis on pathology for CP. So this is a special type of situation. And even the fibrosis here is different. The fibrosis here is actually perilobular and not interlobular. So these are called, and some of the exocrine function tests in a very sensitive manner have been found to be abnormal in these entities, but histologically they are completely different. And I have told you these causes where they can be observed if you have access to pancreatic histology. But the $1 million question is, will they eventually progress to chronic pancreatitis? If so, what proportion progresses is not known at the present time. Dr. Deshpande, did you want to take over the picture?
I have a question. I just wanted to open up to any questions. So, David?
So I'm David Goldberg. I'm a hepatologist. So, you talk a lot about sort of, figuring out or ruling out alcohol-induced pancreatitis. And as a hepatologist, quite often patients say they don't drink or they don't drink much, but we know that they have alcoholic hepatitis because of their liver enzyme profile, their leukocytosis, their macrocytosis, but we've moved more also towards checking alcohol metabolites like phosphatidylethanol, because we don't always necessarily trust the patient's history.
Sure.
Is there a move towards that in pancreatitis before labeling someone idiopathic and doing this workup to actually check alcohol metabolites to see is their history matching what's actually happening and to avoid potentially unnecessary testing?
Yeah. So first of all, a salute to hepatologists, because hepatologists have been ahead of the game as far as alcohol damage on the pancreas is concerned. You have done so much more research in fibrosis markers and coming out with fibrosis scoring, etc., etc. So what we are doing now in the pancreas research is what you have done with reference to fibrosis early diagnosis, then the treatment of fibrosis. We are still not there, what you have done. But the thing is, to be specific to your question, we know that people who have Claudin-2 gene abnormality can develop this. We have set in stone these definitions, 5 drinks or 8 drinks for 10 years or 15 years. We know that it's only just for the sake of setting some definition, but that's not actually how it works. People, like for example, Winston Churchill, he drank like a fish till 92 years and he didn't have any problem. Ate like a pig, smoked like a chimney, drank like a fish, 92 years, 1 heart attack, dies. So same thing with Claudin-2. We are now understanding the predisposition of some folks who take only a couple of beers 3 times a week and getting alcoholic pancreatitis. But we are not checking the metabolites yet, but those are being discussed in the prospective as a sort of studies.
So thank you, Dr. Vege, very much. Unfortunately, we're out of time as we come upon the hour, but
Yep.
I want to thank you on behalf of the department for a fantastic inaugural Barkin Endowed Lectureship. And thank you all for coming. The CME and MOC is in the chat, if you can click on that. Thanks again.
Thank you so much, everybody. And it's indeed an honor to do this, particularly for a man whom I have known for decades and whom I respect immensely. Thank you.
Thank you, Santhi.